This is our agenda. We'll come to that in just a minute. Next, please. The activity is supported by an unrestricted educational grant from Medtronics, for which we're extremely grateful. Next, please. You'll be able to get CME credits for this program, and there will slide about it at the end as well. So let's go back to the live view. And you take that off.
Oh, the slides are down.
Okay, all right. Hello, everyone. This is Tanvir Rab. On behalf of SCAI and the SCAI Bifurcation Club, thank you for joining us. I'm pretty thankful to George Angus for inviting me to the SCAI Bifurcation Club and supporting my efforts in starting his monthly bifurcation webinars under the auspices of the SCAI Bifurcation Club. Special thanks to Medtronics and also to Rebecca Burwell and Eric Kramer from SCAI making this possible. Our esteemed guests today are Yves Louvard from the European Bifurcation Club, really the founder of that club, and Francisco Berzota, also from the European Bifurcation Club. Our own Azim Lateeb will talk to us from Montefiore in New York, and our chart moderator is one of our senior fellows from Emory, John Lisco. The focus of the webinars will be case presentations with discussion of different treatment strategies, including imaging and physiologic evaluation. Didactics will be at a minimum, but we will periodically have presentations on important topics. So without much ado, I'm going to invite Azim Lateeb to start his presentation on an update from the European Bifurcation Club.
Thank you, Tanvir. I assume everybody can see my slides. You'll let me know if you can't. It's a real pleasure to be in this. I've been very fortunate to be able to work with both Europeans and Americans on bifurcations and be able to share my experiences of both. But I have to admit, for many years living and working in Europe, I've gotten to learn so much from the European Bifurcation Club, from Eve, from Francesco, and the rest of the team. And so it's an honor for me to really talk about their document. I'm not an author in the document, but two of the senior authors are here, so they can comment on it too. What I love about the European Bifurcation Club is that every year they try and come up with a consensus document, which really highlights the important parts of what we need to know about bifurcations. And they always try and keep it very practical. And there's no sort of like dramatic change from one year to another. It's always building on the previous year and what we've learned and how clinical data impacts our choices. So, one of the most impactful ones I've read is the 15th consensus, which was from 2 years ago, done by Francesco. And since then, from then to now, what's really changed? There have been a couple of really important papers that I think have impacted the guidelines and have impacted how we think about bifurcations. The first is the EBC main study, but Yves Louvard is the senior author on that, and many members of the European Bifurcation Club included on that. And we should maybe talk about that first. This was a randomized study, and I think a very important randomized study, because it was a randomized study evaluating a strategy in distal left main lesions that affect both the main and side branch. And I think what's different here is that these were important side branches that was part of being in the study with lesions in the side branch. So, these were lesions, real lesions in the side branch. The true bifurcations were lesions in the side branch. And patients were randomized to either stepwise provisional strategy or upfront two stent strategy with crossover allowed. There was about a 22% crossover rate to second stent. And the technique was used in half was tap and the other half culotte. For the upfront two strategy, and I think this is interesting because it's a little bit different to what we see in the United States, that in Europe, the preferred strategy in the study for upfront two stents was culotte in more than half. In my experience, having worked here in the US, I think many operators prefer DK crush, but I think both these strategies are good. You see DK crush was only in 5%, tap in 33%, but very importantly, very high rate of final kissing balloon inflation in 93%. The primary outcome was at 12 months, and you see no difference again between a provisional approach and an upfront two-stent strategy, which I think we've seen in many of these similar randomized studies. The other studies, which I think is important for you to know, and then I'll quickly go through what's changed in the document, is the definition study, definition 2 study. Here, the authors tried to really give us clear criteria of what a complex bifurcation is, looking at the complexity of the bifurcation, how much calcium, the severity of the disease. So not the typical bifurcation that we all know will do well with a provisional strategy. And here again, the intervention was a two-stent approach, DK crush in the majority, 78%. Remember, most of these patients were treated in China, or all of them were, and so that is the preferred two-stent strategy. The control group was a provisional approach in the rest of the patients. And again, a similar rate of crossover, about 22%, which I think is for left main probably true, or for really complex bifurcations true. Probably in the more simple bifurcations, that rate is probably lower, and the preferred strategy was TAP. And I think what's interesting about this study is that if you select out complex bifurcations with a lot of side branch disease, with a lot of complexity, we do see that in those patients, they do better with a two-stent approach. And you see the target lesion failure rate here being about 37% lower with a two-stent approach. So the newest documents are the 16th expert consensus document. First authors are Remo and Jens. I cannot go through these documents with you online. They are really extremely thorough. And I would suggest, if you're really interested in bifurcations, you want to know how to get yourself out of trouble and what are the potential pitfalls, for you to really read these documents. They have some amazing images inside of them that I think will really help you get great outcomes. I'll highlight maybe a couple of important things from both documents. So I think the first thing is the fact that most of us accept that the provisional approach is the best approach to deal with the majority of bifurcations. But we all need to also be saying the same things, in that the provisional approach is done in a very specific way. So I think we all agree now that to do a good provisional approach, you should wire both branches. If you think this bifurcation is important, the days of only putting a main branch wire are gone. We shouldn't be seeing side branches occlude because there's no wire in, and that we're systematically jailing the side branch or the side branch wire when we put the main branch stent in. We usually, in a provisional approach, mostly prepare the main vessel unless the side branch has a very tight stenosis. We don't usually dilate it. And then we have to also think about optimizing. So there's a great figure, which I love in this paper, which really goes to the provisional approach. And I think, this is how we all should be performing the provisional approach, right? It starts after predilatation. We choose our main vessel stent based on the distal main vessel diameter. So based on that diameter, not the proximal diameter. And by doing that, we prevent carina shift, which is the most common cause of new side branch narrowing. When we do that, however, our stent is under deployed or non-opposed in the proximal main vessel. And so we need to then, the next part of the step is to do a POT, a proximal optimization technique, where we use a small balloon. We should try not to cross the carina with that small balloon. And that small balloon will then oppose that stent and facilitate, if we need it, side branch access. In many cases, I think the procedure can end here. You're done if you have a good result in your side branch. If you have a suboptimal result in your side branch, or it's compromised, then usually what I do is really, step 3 is I get another wire. I go with that wire into the distal main branch. I then pull back and I rewire into the side branch, and then remove my gel wire, being careful about the guide catheter and not sucking it in, and then follow with a kissing balloon inflation. Some operators also prefer to repot after the kissing balloon inflation, just because of the concern that the two balloons will ovalize your stent And so by doing a pot again, you circularize the stent. And then you assess what the result is. The result looks great. You're done. If you're concerned about the result, you may then think about crossing over to a second stent. I think one of the things that are most important, and these are some pictures from the visible heart, that really shows you the visible heart, how stents look when we're in a bifurcation. And one of the things I think I've learned from doing the visible heart and doing provisional on the visible heart is the fact that it's really important to do the pot. Because if you don't do the pot, your main vessel stent is really underposed, and you really then are challenged, and you risk doing this, where your wire is going to go outside the main vessel stent. And in the paper, there are a lot of these tables, which I think are really useful. What to do when you run into trouble, what to do when you're struggling to wire, into the side branch and you think you're getting stuck. How important it is then to redo your pot, maybe choose a third wire, and think about where you place your pot, or whether you would need a dual lumen catheter. So I would really, suggest looking at the paper. I really like the approach to understanding what the pitfall is, what the mechanism is, and then troubleshooting it, and then how to prevent it, because I think many of these problems can be prevented. Then here's another example, I think, that the paper covers very well. It's when your balloon does not cross. And why doesn't it cross? And many of these cases in provisional can really be prevented by doing a proper pot, placing the pot balloon in the correct place, using the correct size of the balloon, and really making sure that your balloon is well inflated. And so the whole paper really goes through this sort of stepwise approach of how you do a approach, whether it's provisional or second stent approach, where you potentially will have pitfalls, and understanding what those pitfalls would be. For example, could it be getting your wire stuck outside stent struts, not doing a proper pot? So troubleshooting that in your mind, and then what the solution is. Number one, usually the best solution is preventing it, but in case you haven't prevented it, how do you actually manage the problem? So I'll really say it's a great paper. The first paper covers provisional, the second paper covers double stenting, and it really goes through each of the approaches and where you can run into trouble. I would just maybe summarize the approach to two stents as, I think the use of which technique you use should be selected according to the anatomy and your experience. Learn one approach first and learn to do it well, and learn to do the steps well before trying to do 3 different approaches in a week in 3 different patients. When you think that bifurcation is complex because it has a large and very diseased side branch, usually an upfront 2-stent strategy will give you a good outcome if you do it with meticulous technique, which also requires meticulous lesion preparation. I think the other thing to remember is when you're worried about the side branch, when you're worried about re-access, about it occluding, that's when a 2-stent strategy is useful, because what's different between a 2-stent strategy and a provisional is that you're really deciding that you're going to stent the side branch first. Remember that a provisional approach does not preclude crossing over to 2 stents. You can decide even in a bifurcation that you may think will require 2 stents, you can start provisional and then cross over to 2 stents later. And then think about the pot. I think I often, when I do a technique like a culotte, I probably do 3 pots during a culotte. You need to do often multiple pots. And also the importance of final kissing balloon inflation. When we do 2-stent techniques, I used to do it for some of my techniques, but I learned from Francesco that I probably need to do it in all my techniques, where before I do the kiss, probably it's worthwhile doing very high pressure inflation in each branch and then doing your kissing inflation. So really, I'll end here with my key messages from the 16 consensus. I think the most important thing when you do bifurcations, as much as possible, and this is probably for PCI in general, is keep it simple and safe. Try to limit the amount of metal. The provisional stent strategy, and I'm sure even Francesco will talk about it, it's more philosophy and is a philosophy. It's about trying to keep the procedure simple, safe, minimizing metal, but it's also dynamic and does allow you to cross over to 2 stents when you need to and when you need to get a good result. In order to get a great result, it's really important to understand what can go wrong so that in most cases you can prevent it. But sometimes if you can't, at least not understand the pitfalls will help you correct it and getting a fantastic optimal outcome in the end. So thank you for your attention. And it's always a pleasure to be on the SCAI Bifurcation Club and being part of this session.
Thank you so much, Azim. So I'm going to invite Yves Levard to co-moderate this with me. Both Yves and Francisco, if you have any comments on before we go on to the cases about these two publications that we're both part of. And John, please choose 1 or 2 pertinent questions to ask, okay? Go ahead. Yves or Francisco, whoever wants to go first.
Francesco?
So on my side, I think that Azim really summarized the concept. His final advices are those that are shared by the BC group, that is mainly, let's try to prevent trying to have sequences of procedures that are anticipated to have higher chances of success. And in the case something got wrong during our procedure, we should we should understand what's going wrong before reacting. Most of the time, the link between understanding and properly reacting comes from imaging. So this is probably the only thing I can add. I mean, on the basis of bench test, everything is clear. However, we should now, having in mind all the tests, all the examples that Azim has summarized and that can be found into the BC consensus documents, we should really rely using the imaging modalities inside our cath lab and what's going wrong. And IVUS and OCT are those that are routinely advocated. Honestly, I think that sometimes also looking carefully at angiography, for example, using stent magnifications tool like stent V or stent boost, can sometimes be very efficient. So we should really select according to the ability we have and capability we have at that time.
All right. Yves, any comments, or should we just wait for the chat question?
Just about imaging. So in my country, we are using a minimal amount of imaging, and this is related to the fact that we have not yet reimbursement. I mean, I understand from the government that we have reimbursement if we have a randomized trial proving that this is better to use imaging instead of angio only. So this explains why during all these years we trying to develop alternative way to analyze the picture. One was said by Francesco is stent enhancement. Also trying to calculate the diameter when using the formulas, the finesse formulas of the Murray, to know what will be the optimal diameter of any segment. So for this and many other topics. So I think intuitively I learned a lot of things by looking at people doing imaging, also bench, also simulation. When we are working on a patient, we can have this in your mind and use all this demonstration like what was done in Minneapolis. All these demonstrations are very important to take decision, even if you don't use imaging. But this year, maybe we'll have an answer about this.
The good news in the US, we're actually being reimbursed for imaging now. So we are doing more imaging now in our cases. John, 1 or 2 pertinent questions. Audience, we can't answer all questions, but we'll try to finish out the ones we think are pertinent. Go ahead, John.
Yeah, thanks, Dr. Rab. So the chat is pretty active with some practical questions. The first being, how do you manage your side branch wire after a high pressure pot? And are you ever having problems with that being jailed or unremovable? And the other is, do you have a specific stent brand choice when you're using a provisional strategy?
Maybe I can answer on the wire. It's also recommended in a previous consensus, I think by Francesco, It's recommended to use hydrophilic wire, which is even gel, they can be removed without damage. And Manuel Pan in Spain has shown damage on non-hydrophilic wire when they are gelled, when they are really strongly gelled in the side branch. So hydrophilic wire, taking into your mind that these wires also can be dangerous, so keep them in the radiologic field.
If I can add something, there are some tricks that can be applied in order to make gelled wire technique a little bit safer. In particular, we should, when we perform a POT, it is exactly the time in which the wire really become entrapped potentially. So this is it is important not to have the wire lying very distal. So keep attention at the tip of the wire in the moment of final gelling with POT, and also most of the time you may pull a little bit in order to avoid that there is any wrapping around the stent. So these are, a specific trick that can make a gelled wire honestly very safe. Finally, a POT can also be performed stepwise. If you have a calcific lesion and you are afraid about entrapping the wire, the wire between calcium and the stent, you may avoid performing high pressure POT since the beginning, and you have also the possibility to optimize at the end of the procedure by re-POT after having wired luminally instead of having the gelled wire.
Great.
So we are not forced to.
So let's go on with the presentation from Francisco on provisional stenting. In the interest of time, we have time at the end. John will again ask questions. So let's Francisco get started. Thank you.
Okay, do you see my presentation?
Yes, yes, we do.
Yes.
Okay. So honestly, I want to explain why we are in favor of using a provisional approach. I think that it is important to see that all the first generation trials, especially when you look at long-term outcome, had strong signal in favor of the fact that in unselected lesions, provisional is better in terms of safety as compared to two stents systematically approach. This is meta-analysis recently performed. We know that when there is a disease in the side branch, if you do not have extensive disease, we have two randomized trials by EBC showing that there is no difference in unselected bifurcation, again with the Medina 1-1, however, disease, through bifurcations, and the EBC main that has been recently also named by Azim. So all of these is in favor of using, as considering valuable the provisional approach. But honestly, what is outside the trials and is a signal that is, a little bit hinder over the trials is the fact that if you look at the very long clinical outcomes in the clinical practice, you may have signals in favor of better safety for single stenting techniques. This is the syntax trial in which you may see that up to 5 years, there is no significant difference in terms of mortality for patients with bifurcations treated receiving 1 or 2 stents, but thereafter there is the splitting of the survival curves in the second part. So especially if we are taking care about the long-term outcome of the patients, there is this signal that deserves attention and may provide reason for trying to spare the systematic implantation of a second stent. For sure, provisional, according to the EBC approach, is not single stent. It means trying to perform PCI in a bifurcation, implanting one stent, and in the case of need, effectively implant the second stent, and I'm quite sure that Yves will convince you about the possibility to implant the second stent. So the case is this, to be summarized. If you have two bifurcations like that, completely different in terms of complexity, and you want to fix it with a single stent like that, it is anticipated that you have higher risk of complication, higher complexity with the provisional. So this means that you should know about the tricks to improve the safety of provisional in the case you want to tackle this complex lesion with the provisional. Anyway, if you are able doing this, you might be surprised to have fantastic results in these two cases with a single stent, like the one achieved in these two completely different cases. And this is the beauty and the potential of provisional. So the case I want to share with you is a young male with classic risk factors presenting with inferior inducible ischemia documented on top of a fourth angina. So good indication. Left system was okay, and this was the lesion into the distal right coronary artery. So short stop point with the panelists, how to treat.
Okay, Yves or Azim, you have a crack at it?
What I will do here is consider the PLA as the main vessel for several reasons, especially the lesion distal to the bifurcation is longer. And I will use provisional strategy, of course, and exchange wire and treat with the balloon and kissing the bifurcation. And in case of absolute necessity, put a stent in the PDA.
Azim?
Yeah, I agree with Yves. I think, two wires. The question here is really, which is your main branch, which is your side branch? And the decision, I think, for me, is often based on the importance of each branch, the territory of distribution as well, not just the amount of disease. So, yeah, I mean, I always think PDAs are really important because they supply the inferior wall. So, Yves, I don't like disagreeing with you. Maybe I would go stent towards the PDA and be provisional on the PL. But I think, I would probably decide after a little bit of pre-dilatation, see how the vessel responds, give some nitro, and then decide which is the larger territory.
All right, let's see. What do you do?
Okay, so we go on. I think that what is highlighted is the fact that in this case, there are multiple choices in terms of options to start this procedure. And in what is recommended for complex bifurcations, and I tried to apply, was OCT imaging, that in my practice is OCT, and you may see how tight is the lesion. This is the bifurcation showing that really there is a lot of plaque inside the two branches. And definitely this is the true Medina 1-1 lesions in which the risk of problems into the side branch does exist. So I think that for people that is afraid about losing the side branch, both angiography and invasive imaging confirmed that there is a risk of occlusion of the side branch in the case of crossover stenting in both branches, because you see that the plaque is in both areas. What we did was to use radial approach, JR4, 6 French, and 2 BMW Universal. Then what we did was to put 2 non-compliant balloons inside the 2 branches, and we expanded the two balloons in a sequential way in order to be sure that this huge amount of plaque was appropriately dilated. We don't want to implant stents that do not expand. So first inflation toward the PDA, but with the other balloon ready, then the balloon for the PL with the PDA balloon ready, and then low pressure kissing inflation. This is something that, I mean, we sometimes do, but this is the kind of situations where we consider doing. As Azim said, the pre-dilation phase is important when you have complexity. And with this technique, the aim is to try to scaffold as much as possible the polygonal confluence in order to reduce the risk of carina shift during our interventions. And this is the pre-kissing technique. So, and this is the situation after.
That's beautiful.
I think that the risk of occlusion of this side branch in any of the two directions is completely different now. I think you may now agree about the fact that provisional is more and more safe in this condition to be considered. And what we applied was OCT, showing that there was for sure some dissection, but look how much space you have in this area, how much space you have here, and look at this carina, how is kept into the middle without having jeopardized any of them, of the two areas. So on top of this, we did what is recommended. We implanted the stent, drug-eluting stent, from the right toward the PDA. We expanded at nominal pressures. This was the result. There was some carina shift expected on the basis of this OCT, but no occlusion. So then we performed semi-compliant expansions 3.5 according to the proximal main vessel. We had all the sizes now well known according to intravascular imaging. Then we performed rewiring with a third wire using the pullback technique. You see here the wire that is pointing toward the PL, and now it is jumping as soon as carina comes. You see this jump inside, and then the kissing is applied with two non-compliant balloons appropriately sized. Then another balloon, another stent has been implanted here proximal, and the same balloon of the stent has been used to further perform a POT that according to the possibility to have this result. This is angiography. This is angiography in another view, and this is OCT showing, I mean, not only absence of any kind of malapposition, but wonderful expansion of the stent. And I want you to emphasize how we changed the geometry of this drug-eluting stent, having this prolonged scaffolding toward the PL that really may explain why the result angiographically was so good. We should remember that if we perform all the manipulations we described, we are able to change the drug-eluting stent platforms in order to have this fantastic adaptation to the geometry. And this explains why provisional may be suitable for Medina 1-1 lesion, and is also at this stage very easy in the case of dissection or suboptimal result to add another stent into the side branch without having, I mean, a long prolapse inside the side branch. So the patient had uncomplicated post-PCI course. DAPT was interrupted after 6 months, and the patient is now asymptomatic after 3 years. Thank you for your attention.
Thank you very much. We have a whole bunch of chat questions. So, John, what have you selected to ask?
Thank you. So there's a question about how you size and choose your balloons for your kissing balloon inflation. So how do you size them first? And then where are you putting the semi-compliant balloon and non-compliant balloon? And then if you could describe your steps to the kiss.
So,
if it's high pressure in both or sequential.
So regarding the phase of predilation, we try to use a size that is one-to-one according to the stent we are implanting. Regarding the predilation of the side branch, honestly, we are always conservative and we do not systematically do. I mean, we do it only in the case we think that it may reduce the risk of occlusion of the side branch, because there is an interesting randomized trial by Manuel Pan showing that in true Medina and in true bifurcations, the predilation increases the risk of the side branch, increases the patency after crossover stenting. So now predilation is considered not systematically, but when you have tight stenosis into the side branch. Regarding the selection of the balloons, you should have a balloon that allows you to understand that you are able to expand your balloon, your stent at the end. So if you have calcific lesion, it is close to one-to-one to the stent you are implanting. If there is a soft plaque, you may consider having a little bit undersizing. I mean, and regarding the use of non-compliant balloon or semi-compliant balloon, we are using more and more for predilation non-compliant balloons, and for the post-dilation, again, non-compliant balloons as much as possible. For POT, if there is no huge plaque, you may consider using also semi-compliant balloons. So this is an overview of the balloon selections.
And then for the final kissing balloon inflation, you're using 2 non-compliant balloons as well?
Yes, if possible, yes. I mean, it is not something that is associated with the long-term outcome benefit, but the concept is we need the non-compliant balloon to optimize the result on the stent, okay? So you need the non-compliant balloon, and most of the time I like to have the sequential kissing so that I can check if it is well expanded into the main vessel. For the side branch, the non-compliant balloon offer the advantage of reducing the dog bone effect that is related with the interaction with the metallic material of the stent. So it is reported to be associated with less risk of side branch dissection.
One final thing, Francisco, when would you use a drug-coated balloon? Would you use a drug-coated balloon side branch here or not?
We honestly, in the EBC, there is a lot of discussion in the last years about the role of drug-eluting balloon, and their potential for side branches is one of the more recognized inside the group. However, honestly, actually, we do not have enough data to recommend their use. So I think that is the ideal setting for future studies.
Thank you. Great talk. In the interest of time, we need to go on to Yves Leward. Yves Leward is really father of the bifurcation clubs and really set it up many, many years ago in France. That really fascinated me. And, he really started the European Bifurcation Club and the worldwide attention to bifurcation. So let's get Yves started. All right. Welcome, Yves.
I try to maybe.
You're on. The screen is on.
Okay. Here I am. So good evening, all. First of all, I want to thank SCAI and especially Tanver, Rab, and George Dangas for the invitation in this webinar dedicated to what I consider my last topics, European Bifurcation Club and coronary bifurcation stenting. I was asked by Tanver to present the case of provisional stenting technique ending with double stenting. The talk is enriched by a recent publication of the club. I will show here the 13 consensus written by Francesco Borzotta, which is 2018. The EBC man was cited already, written by that. And more recently, a sub-study of this trial written by Sandeep Aruno Tayaraj, dedicated to technical details. I choose a case of left main bifurcation stenting, easy. on a 60-year-old woman. She's my colleague and my friend, and she's suffering a severe effort angina with a spectacular ST change during stress test. She was previously treated for Hodgkin disease with radiotherapy. The lesion is Medina 111 on left main LAD CX. This notation tells you that I consider the LAD as a main distal vessel. There is also an ostial lesion, moderate, on the RCA. The provisional strategy begins always, it was said, by a systematic double wiring, which will help you to keep the side branch open, localize the side branch in case of occlusion, and allow the use of a salvage technique using, for example, a small balloon on the gel wire to regain a side branch flow. We always, for wires, we always begin with the most difficult branch access. During wire insertion, we limit wire rotation to 180 degrees. We keep and change the positions of the two wires on the table to avoid crisscross. Using a hydrophilic wire, avoid deterioration of the wire during pot, for example, and removal. Choose a wire distal shape longer than a proximal segment diameter. Use sometimes a double shape if necessary, a hairpin shape for reverse wire technique. In case of failure to enter a side branch, we can use a shaped microcat or even a retablation of the main vessel. Then crossover predilation is performed, as you can see here, with a balloon which is selected from the LAD diameter. In this case, side branch circumflex was not prepared. After balloon, the side branch is still there, as you can see. Main vessel crossover stenting is then performed with a DS size 1:1 according to LAD diameter. Here, 3.5 millimeter. The proximal part of the stent has to be at least 6 to 8 millimeter long to allow the use of a 6 to 8 bigger balloon for pot. But here in this situation, the stent is positioned at the ostium, so it's okay. We have not risk of geographic risk. Stent deployment has to be long enough to deploy properly the stent. And I currently do 2 or 3 inflation, depending of the duration, depending of the tolerance, and the pressure adapted to the diameter of LAD. Don't go with a semi-compliant balloon to very high pressure. You may push the carena and close the side branch. The crossover stenting, the circ is still patent. And clearly, the stent is under-deployed in the left main. So the predictor of side branch TB flow less than 3, found by Sandeep Aruna Tayaraj, no influence of angle, no influence of Medina, nor acute coronary syndrome, even side branch lesion length, preparation and gel wire, and but only the presence of a moderate to severe calcification. So the predilate the ostium of the side branch if calcified is probably a good idea. Systematic first pot is done with a balloon size 1:1 to the left main. Here, a 4.58 millimeter. Of course, this is protruding in the aorta regarding the shortness of the left main. For a pot, the distal marker of the balloon is in front of the carina. If the proximal part of the stent is long, a more proximal pot has to be performed to avoid the bottleneck effect. A consequence of the tapering of coronary vessel at the level of each bifurcation only, we have to choose the crossover stent adapted to the 2 diameters, the distal and the proximal. And here is a chart showing, it's quite old, showing how to choose a stent to adapt to a 4.5 left main and a 3.5 LED. After pot, we see, I think clearly here, if you look cautiously, two diameters along the stem. Circ is still patent with an apparent very tight stenosis. In fact, this is certainly a carena shift. Technical advantages of pot are avoiding wire exchange outside the proximal part of the stent, was shown by Francesco, open the sails for easier wire and balloon crossing. Now it is time to wire exchange. So for the left main, we don't remove the LED wire and push it circ and then remove the circ to put in LED. We use a third wire in order to improve the stability of the guiding catheter. Pullback from LED is used to enter the most distal cell towards the circumflex, using a long shape in the prepared wire. Then take care of guiding catheter, keep it out of the ostium to avoid longitudinal distortion during a side branch wire degelling. So on the left, you see a proximal recrossing, which is responsible of a neocarena. And on the right, top to bottom, you have a distal recrossing where you push the metal on the lateral wall of the side branch. When the crossing is proximal, then you create a neocarena. I'm sorry, I missed something. When the recrossing is distal, then the proximal part of the stent is projected to the lateral wall, as I said. So here is the case of left main longitudinal stent distortion. You can see dark dots that representing overlapping struts seen easily with stent enhancement. A second stent has to be implanted proximally in this case. Here is a series from Excel by Akiko Maera showing the clinical consequences of mainly unrecognized distortion. So this is, as you can see, a severe problem with an increased rate of MACE, an increased rate of left main related MI, and left main ischemia-driven TLR. After wire exchange, side branch predilation. The only one predictor of failure to rewire was the absence of gel wire. This is an important validation for gel wire. After wire exchange, it is time to prepare the side branch with the NC balloon using pressure to fully open the vessel. I don't explain why we use an NC balloon, was explained by Francesco. Followed by a kissing with main vessel balloon size 1:1 according to distal main vessel, and side branch balloon avoid dissection. Size on the side branch diameter. This is the best technique to put the carena in its physiologic position. Now it is time to decide to stent or not the side branch. I have to say that from the beginning, I was thinking I will have to put the second stent, but we can, for example, looking at this picture, can decide not to put. Requirement for further side branch intervention, funded by Sandeep, early preparation of the side branch, but not perform, non-NC only kissing balloon. NC is important, it was said. Only a trend for side branch disease more than 10 millimeters. So this means that we don't have yet a cutoff value from EBC mail for double stenting. A side branch, oh, this one. The side branch preparation is a factor of dissection. After kissing balloon, I decided to stent the circumflex artery. Maybe because I consider that this lesion was related to radiotherapy, because my colleague have a very safe life and no risk factor. So how to choose the technique? Sorry. How to choose the technique? As said, the distal crossing is associated with a favorable main vessel stent deformation. you can see here very clearly with stent enhancement. After ballooning to allow to perform a stenting without stent protrusion. Stent enhancement is so very useful. If you have a side branch lateral wall metal projection, then you can perform a T-stenting. If you not have it, you have a neocarena, and then you have to perform a tap. And you see on the two pictures in the middle, at the top, a projection of metal laterally, projection of metal inside the vessel, so neocarena, and at the bottom, a projection of metal laterally, ideal for stenting. Or you can also use mini culotte to do this double stent annual DP stenting. This is provisional. This is part of the provisional strategy. So I decided to implant a stent in the side branch as a T-stenting regarding the protrusion, and you can see here that it's a bit proximal, like for a tap. So a good positioning of the side branch is essential in the best available position, best radiologic position. If two second side branch stenting will be necessary. If too proximal for a tap, you have to convert the procedure to internal crush. It will be necessary. The performance of an additional high pressure balloon following partial withdrawal of the stent balloon is recommended in order to achieve optimal stent expansion before the final kissing, which is here, performed after immediately after the stent deployment using the side branch stent and the main vessel balloons. Simultaneous balloon deflation to avoid carena shift. The result was considered good, but nearly always doing a final pot. It's as it was said by Azim, this is to correct ovalization. And this pot, of course, has to be more optimal than the first pot because we don't want to crush a stent or to move the carena. This a very good result without any acute MACE, persisting at 7 years without symptoms. So the predictors of periprocedural MI are non-NC only kissing balloon inflation. And there is a trend for when the side branch was not rewired. So I'm coming to my conclusion, which is coming from David Smith. So the stepwise provisional approach is rigorous, logical. This is flexible, versatile. You can change your mind all along the procedure. And it offers option to do less rather than more. And I think it's important regarding the long-term outcome that was shown by Francesco. Thank you very much.
Well, thank you very much for great presentations. We have 7 minutes to take questions. So John, shoot the question, see what people have asked and what you have chosen to ask.
Thank you. So there are questions that if you have a borderline lesion after a provisional strategy, do you ever use physiology assessments to guide the implantation of a side branch stent?
Regarding the case I did, you have seen that after kissing, before the second stenting, I had an acceptable result in the circle. I'm completely sure, 100% that the physiology will be perfect. So what we encounter is the contrary. When sometimes after implantation of a crossover stent and a pot, on the side branch, you have a very tight lesion at the ostium. And Dr. Koo from Korea have done a systematic evaluation of this kind of lesion with FFR. And he showed that at least 50% of these tight lesions are not physiologically true. So because this is related to the carena shift, this moves the ostium of the side branch from a circular anatomy to an oval anatomy, or sometimes even to a slit. So this gives, in the only one projection we have, the impression that we have a tight lesion. So it's very rare that when I have the result I showed you after the implantation of first stent, it is clear we can avoid to put a stent. And when the lesion is very tight, maybe I will use physiology. And in case of FFR more than 0.8, I probably won't implant the second stent.
I would just add to what Yves said. Don't forget that FFR, IFR wires are difficult to manipulate. And so sometimes if you've just put your stent in, you haven't done a kiss, it can be really difficult to get through stent struts. And the other part of Koos paper is that sometimes if you've just put the stent in and the side branch ostium doesn't look great, and even though the physiology is important, probably the next best thing to do is a kissing inflation, and it will correct the physiology in many cases. So,
Very good.
All right, John, what other questions do you have?
There's another question, Dr. Levard, that you had mentioned reverse wiring, and people were interested in that technique, and if you could describe how you do it.
Reverse wiring for difficult access side branches, we can use reverse wiring, which was discovered commonly with Jens Lassen. Francesco also was one of the pioneers in here. I was also in Korea, it was used in Japan. So what is a reverse wire? Is to use a wire you give an hairpin shape. No, this is a 180 angle, and with a small distal shape pointing the side branch. So, for example, using a microcat, you move in the main vessel distal to the side branch, and then you will pull a bit your microcat, and you pull slowly the hairpin-shaped wire, and it will enter the side branch by pulling. This is surprising, but this is a very effective technique. You have to be a bit patient and to properly prepare your wire, but this is a precious technique.
and maybe I'll add to it as well, is that I think now with the Supercross, especially the Supercross 120, it's become a little bit easier to get
it's easier.
The back ones. The only thing I often see people with a Supercross, you have to be careful though with a Supercross, because if it's bent backwards and you're not really facing the ostium and you try and push out too hard, you can easily dissect. So it's a great tool, but be careful with the Supercross, but it can help you in the very difficult bifurcation.
All right, what else do you have, John?
Thanks. There are some questions. T or tap? Is one better in terms of final area, and what do you prefer?
I can.
Yeah, you can answer. Because
Yes,
I think we are okay. We are okay.
No, I feel the responsibility to give clear answer regarding tap and T. So tap has been developed with the aim of warranting final kissing inflation. So the true adding benefit is the fact that with tap, you have the balloon uninflated in the main vessel that is set before. And this was not the routine with T-stenting. But the ideal tap is C. So we should really be careful in avoiding generous neocarina. So what I like is to add tap on top of having done all the manipulation I showed during the case and shown by also Yves Louvard during his case. So on top of this, most of the time, you have the possibility really to have no protrusion, no long protrusion inside. For sure, since one of the pitfalls of T-stenting can be the fact that you miss the ostium, that is the area at higher risk of restenosis. The fact that the balloon is ready for kissing and you are prepared to have final kissing inflation, even in the case you have some neocarina, allows you to be, in the depth, free to cover the ostium with more confidence. But really, it is important to keep time to prepare before, and then to keep time to find really the best incidents to minimize the length of the protrusion inside the main vessel.
You know, John,
If am I correct or not?
You're perfect. You're perfect. This is I think you focus on the projection. I think it's good when you are dealing with a bifurcation to have a working projector, the one you don't turn from the beginning to the end, and it has to be selected to show a perfect separation of the vessel. Sometimes it's quite difficult to find, and I cannot describe that. We don't have time, and of course it's very different from one legend to other one.
Last comment, sorry, I want to fix this at best. In the case you are not 100% sure about where the ostium is, it is better to perform a culotte so that you have no problems inside the polygonal conference. So you protrude a little bit more, then you perform POT and you perform kissing. I think that is the only condition where I like not to perform a T-tap, when I'm not 100% sure to have good visualization of side branch ostium.
I agree with this.
all right, we're coming to an end. Thank you for great presentations. And this was really very good for the first webinar of the SCAI Bifurcation Club. Now for the audience, we'll be holding it on the last Thursday of each month at 6 p.m. Eastern Standard Time. We may not have it when SCAI annual meeting takes place for the month of May, but the next session will be in April and then in June. Okay, so those are 2 sessions coming up, and people will get CME credit for this. Thank you very much. I'll ask the SCAI staff to again project the page for the credit page for this conference. Once again, thank you very much, Yves and Francisco and Azim, for joining us. It was really wonderful to have you on board for this excellent presentation. Thank you very much. Appreciate it.
Bye-bye.
Bye-bye.
Bye-bye. Enjoy.
Thank you
Thanks,
very
everybody.
much.
Have a good evening.
Hi, friends.
Bye.